So the homologous recombination and nucleotide excision repair pathways are important pathways in our cells that repair errors that occur. And so these are really important for normal cells. And then in cancers, what we found is that a subset of cancers, all different types of cancers, first really characterized in breast cancer and ovarian cancer, there's a substantial fraction that have disabled this repair machinery. And as you can imagine, this is advantageous to the cancer cells to not repair errors, and they accumulate in the cells and allow them to gain some cancer-like features. So the mutations, when we're thinking about these disabling these repair mechanisms and which cancers have them, the known mutations in pathway components, such as BRCA1, BRCA2, they weren't as readily found in gastric and esophageal cancer. So that's where we started getting interested in, do these cancers actually have a subpopulation that are truly deficient in homologous recombination, for example, the most common repair mechanism that's disabled in cancer. And the fact that there was a few or a smaller fraction of cancers that had mutations in BRCA1 and BRCA2 made us wonder, is there more cancers or subset of these cancers that are truly homologous recombination deficient, but they don't harbor the mutation. They have another mechanism of disabling the pathway, even one that we don't know with our current understanding of these pathways. So building off of that last sort of ideas of, okay, how many of gastric and esophageal cancers are mutant in these pathways or have disabled HR machinery, homologous recombination machinery, we collaborated with Zoltan, and I want to give credit to his group for really being at the forefront of genomic technologies and the ones that can measure accurately signatures are what we call genomic scars. So they were able to look at all cancers in a consortium such as TCGA and beyond, and analyze the genomes and look for patterns that indicate homologous recombination deficiency. So let me explain that a little bit further. If the homologous recombination pathway is intact, you would expect that certain mutations are being repaired and they're not found in the genome. And so when you're interrogating the genomes of cancers and you see this pattern of errors that aren't being repaired and they're at higher frequencies than you would expect, that's where you can develop a quantitative score of mutational scars or mutation signatures that suggest functional HR deficiency. So this has been done for breast cancer, ovarian cancer, and they developed a CLIA certified diagnostic test. So we thought, let's try to apply this approved test to gastric and esophageal cancer for two reasons. One is to understand, are there more HR deficient cases than is being led on by finding a BRCA1 or BRCA2 mutation? And two, this will make it easier to translate into the clinic. If this has already been approved for another cancer type, maybe we'll have an easier time getting it approved for gastric and esophagus cancer. And so that's where we asked, how many HR, is there HR deficiency in gastroesophageal cancer by this mutation signature score? And the answer was yes. All the cases that had a BRCA1 or BRCA2 or another related component of the HR pathway, such as PALB2, all of those mutant cases were found to have a high HR score. And then we found many others that did not have a known mutation. So if I were to give you numbers, it would be about 3 to 5% of gastric and esophageal adenocarcinomas had the known mutations and pathway components. And then if you then asked how many had a mutation signature score that was above a threshold that was actually calculated in ovarian cancer, so we don't know if that's completely accurate for gastric cancer, but we still use that cutoff, and we found that 28% of gastric cancers were above that threshold and suggested of these could be HR deficient gastric and esophageal cancers.